Well, friends, welcome to next Rita Sood Memorial Oration Award and Lifetime Achievement Award. I request Dr. Purnima to take over as Master of Ceremony.
Thank you so much, sir. MU India extends a warm welcome to you all at the Dr. Rita Sood Memorial Oration and Lifetime Achievement Award. Project Samman, it's a MU India initiative to honor the doyens of medical education in India. The topic of today's oration, strengthening medical professionalism by our very own Professor Avinash Supe, a name that needs no introduction. However, as a ritual, the privilege of introducing Professor Supe sir to the august gathering here. Dr. Avinash Nivritti Supe has been the former Director and Dean, Medical Education and Major Hospitals, MCGM Mumbai, Emeritus Professor of Surgical Gastroenterology and Medical Education, SAIT GS Medical College, Mumbai, Founder Director, GSMC, FAMER Regional Institute. Sir has been the recipient of the much coveted Dr. B.C. Roy Award, besides the other 51 awards at state, national, and international fora. Sir has been the Secretary, President, and Chairman of several prestigious Secretary, President, and Chairman of several prestigious associations. And he was the ex-chairman of the Expert Group Medical Council of India, and he's the chairman, convener of the Expert Group National Medical Commission. And he has been the past president of the Academy of Health Professions Educators of India. Sir has been trained at Memorial Sloan Kettering Cancer Center, New York, Hamburg. He was a FAMER Fellow of the batch 2002, International Fellowship in Medical Education in 2007, Master in Health Professions Education, University of Illinois, Chicago. Sir has to his credit 7 books, 12 booklets, 305 publications, and more than 400 presentations across the world. He has been on the editorial board of very prestigious journals. He has been the past associate editor of the Clinical Teacher. Sir has delivered several orations besides the one which he is going to present today. These are some of the known facets of Sir. The lesser known facet and his passion, besides medical education and his interest in surgical gastroenterology, Sir is a hardcore social worker. He has his immense passion for photography, wildlife photography. Sir writes column, and also he has the passion for nature, this he lets out in the form of trekking and hiking in the Himalayas, Kailash, Mansarovar, Everest base camps, and Antarctica. So here, ladies and gentlemen, I present before you this multifaceted personality, a mentor, a guide, a teacher to all of us, Professor Avinash Nivritti Supe, sir. I welcome you, sir.
Sure. Thank you, Purnima. I think it's a really, for that generous introduction. I will just open up the presentation. Okay. Are you able to see my slides moving?
Yes, sir.
Yes.
Okay. At the outset, really, thank you so much for this honor. I really don't know whether because the previous speakers were all my teachers, so I really don't know whether I deserve, but I accept it with all grace from Tejinder and Sanjay. Thank you so much. I would like to thank MU India, Dr. Tejinder Singh and Dr. Sanjay Bedi, all the organizations which I worked with them, from NTTC to ICMR, MUHS, FAMER, MCI, my own institutions, all the organizations where I have been associated very closely with the national and international level, my own expert group and reconciliation board, all my teachers and colleagues and my patients and family. Now, to talk about Rita is a very emotional moment for me. I think I met Rita in 1995 in the WHO consortium workshops. And I think then from 2005, I met her in FAMER. She was the FAMER Philadelphia Fellow in Philadelphia. And then I was always with her as a global faculty. And then, of course, in MCI committee. From 2007, we started NCME, NCHP, and GSMC famous. She was a regular faculty member. 2010, we were part of the PG committee who created Vision 2015. And from 2012 to 18, development of AHP, and I'm sure with all these organizations, we had conferences all over the world. I think talking about Rita, she was an astute clinician. She was a passionate educationist, great thinker and writer. I think she had a great, she was just INTJ, and I'm sure she used to really think beyond the regular borders. Organizer and networking, the way she conducted herself as president of CIRAMI and WHO meetings. A great friend, colleague, co-writer and supporter. I think she was to me like my sister. What is most important to her was clear thoughts and visionary. I remember once I met her during her illness, and she had a very clarity of idea, and she said, Avinash, I thought this will be very quick, but I think it's prolonging. I think one person who has faced cancer very, very calmly, and she really fought it very well. I think we all really remember her, and we would like to really continue to appreciate her contribution into medical education in India. One of the topics she was passionate about was medical professionalism. Medical professionalism, the essence of medical professionalism is placing dedication to the welfare of patients above physicians' personal or proprietary interest. Very simple definition.
So your voice has been...
Hello, can you hear me?
Yes, sir.
Okay. So if you really see in last few years, what has changed? We have come from blackboard to smartboard. With information easily available, students now learn with Google and not with teachers. Now that is a major change which has come. Easily available data, all technical innovations and images. It seems we know more about patient diseases. We can be doing reconstructions, we are doing proctographies and reconstructions. With everything available, doctor feels he is in much more better control than he was few years ago. She or he treats CT scan reports and numbers. But with this control and computers, we have lost novelty, intuition, trust of patients, compassion, and empathy. Now, this is what is a concern today all over the world. And many patients today complain that doctors did not look at us or touch us. She or he only sees reports or was seeing computers. A very common complaint by patients. And this is alarming as we need to bring back care, responsiveness, values along with attitude, ethics and communication back to practice. Attitudes influence behavior. Developing and maintaining proper attitudes by medical students can impact on the quality of healthcare delivered to their patients as they assume the role of doctors. So let us talk about affective domain. I'm sure this is one area which we don't talk so much. Now, look at Sushruta and Charak Sanhita. Friendship, sympathy towards sick, interest in cases according to one's capabilities, and no attachment with the patient after his recovery. That's what Charak said. Now we are talking about Charak's Shapath and all that kind of thing. It is the physician's duty to look after him as his own son. This is what Sushruta said. So how do you develop attitudes and values in your patients or even your children? Now, if you look at mythology and values, it has always been role modeling. People always say we look at role models. Attitudes are learned by role models. And you have plenty of stories in our mythology. We have Krishna and Arjuna, Aruni and Daumya. We have Yudhishthira and Yama, Hanuman and Bhim. And I'm sure recently Charakya and Siddhartha. So all these will stories of role model. I'm sure mentorship, whatever they used to call. So health is wider than medicine. I think this is one concept all of us should understand. Health is not only giving prescription to the medicine like say amoebiasis, you give Satrogil. No, it's much more wider than medicine. And therefore a doctor who created, he needs a wider vision. A person who studies only one branch of science cannot arrive at a proper conclusion. And therefore, a physician should try to learn as many related sciences as possible. And this is from Shushruta Samhita. And see, so many years before, people have realized the value of the wideness in the health. So how do we learn attitudes? It's a positive reinforcement influences our values. It's our thoughts, actions, behavior, and value character. And it is a cycle which we go through every day. So how do we include this in our medical curriculum? Now, this is a challenge. Now, there are various approaches. One of the approaches is ABCD approach. A very simple approach. Attitude pertains to mental or emotional dimension, while behavior is how one expresses oneself in action. So you teach, try to tell them. So the board competencies are already defined, broad competencies. And educationists must be charged with active training of the acquisition of ethical and professional behavior. That's what the West is trying to do it with milestones. I'll talk about it later. Attitudes often dictate behavior. For example, one who believes strongly in humanism may provide compassionate care across the board. Communication, as you all know, is one of the most important aspects of our professionalism. Patients and relatives, the way you speak, the way you pause, the way you give them support, also in scientific writing and during presentations. One of the most important aspects today is what is called as respecting diversity. What is called as cultural competency. You know, one of the first things we were taught in FAMER was about cultural competence. To communicate efficiently and treat effectively, medical students must appreciate and respect these differences. If you really look around, yes, we have so many differences, different kinds of biases, but we need to respect that diversity. And lastly is empathy. Empathy is ability to put oneself in patient's shoes. I'm sure everybody talks about this empathy, and there has to be balance between detachment and empathy. Now, this is something which is most difficult, but you have to learn over a period of time. Now, what I'm going to do is I'm going to share our efforts and approaches for last, say, 32 years on how we try to work on attitudes. Now, we started working on attitudes with our program called Shidori. Now, Shidori is provisions for journey, pack, and it's a packed lunch people give and given by mother with affection. And this is a story that every time somebody goes out for some job or school, mother packs food for him. So Shidori in KM Hospital started somewhere in 1990. And it was called as co-curricular activities at GSMC. And there were 4 ladies who were really involved in all this. Dr. Dahanukar, who started it, Dr. Rudina Thatte, and Nima and Sucheta. All these 4 people really took the lead, and the whole community of KEM. There are many teachers who really participated in all this. And we tried to take sessions on them, small sessions on various topics like which were beyond the curriculum, like ethics education, group dynamics, assertive behavior, time management, and doctor-patient relationship. I think Dr. Pharma, there was a very good module from NPTC JIPMA. We tried to use that. And stress management. Such workshops really, and assertive behavior, I mean, so many things we really tried to teach them in longitudinal manner in 3 years. And it was very successful and people really appreciated it. We published it also. Then I went in 1993 to JIPMA and NTTC. I met these 3 stalwarts, which were previous speakers, Dr. D.K. Srinivasan, Dr. Seturaman, and Dr. Anantkrishnan. It was a 10 days of intensive experience. Course was mainly towards cognitive domain, gave glimpse of some skills training, affective domain through role modeling, and I did a project on changing attitudes of teachers, because I thought it was a challenging topic. However, Dr. D.K. Srinivasan told me very nicely, yes, Avinash, you can do that, but let me know, it's one of the most difficult things to change attitudes of teachers. But I tried it my way. At that time, I completed the project. And then came the skills training. You know, we started working on clinical skills training in 1995 with WHO Consortium. We did this workshop and we came out with booklets. I think Dr. Seturaman came out with communication skills booklet in 2000. And this is the day we started redefining the clinical skills from 95 till today. And the process is still on. Now we are much more onto the skills training. Affective domain was mentioned each time, but was not elaborated. It was assumed that it is learned by role modeling. Now, this was all the time our concept that we learn it by role modeling. Now, I went to FAMER in 2002, and they created an educational environment, was exemplary kind of an educational environment. It changed attitude of all fellows over the period. So, at the end of it, I asked Page, I know everybody knows Page Moran and William Burdick. They are the two co-conveners of this particular FAMER. So I asked them, how do you really develop this environment? And she gave me some of the tips. Ask all with their first name, speak slowly, develop group norms, value everyone's contribution, rotating groups. And I think she told me so many points, which was the reason why they developed the attitudes and changed the attitudes of people. And she developed tips for the positive educational environment. She talked about motivational interviews, appreciative interviews, see, track, and fan the small positive behaviors, videos to create, to celebrate what right with the world, and express gratitude of activity. And of course, there are many small things she told, which created a positive educational environment, which changed the attitude of fellows by the time they finished their fellowship. And I think this made me think, yes, it is not purely role modeling. There are many steps which we can take. We can really start making people aware of this and stimulate them. Maybe the change will come on its own. Now, positive educational environment not only improves learning, but also changes attitude of fellows. And we all have experienced it through whether it is SAME, basic course, or FAMER, or many other fellowships. I think all of us have really learned how we have changed these attitudes. Simultaneously, all over the world, if you look at the American Board of Medicine, they came out with Project Professionalism. Because all over the world, people were saying that affective domain, people had problems with people's behavior, doctors' behavior with the patient. So Project Professionalism came into picture. And there were tips for educational environment, there were case-based approach, and evaluation. And this was implemented in 2004. And then later on, it was refined in 2012 with the milestones. Now, simultaneously, I was involved into ICMR 2003, which was a great experience. ICMR selected 5 universities that time to develop ethics education and case-based development. I think Sanjeev Lewin was there, and there were many people from South India, 2 people from every university, about 10 people, and we developed the curriculum, and which was first published by MUHS and Curriculum on Ethics Education, and we implemented in 2004. I think Dr. Shingare was with me, and Dr. Bapat and Dr. Dondavkar were the vice chancellors. We did workshops that time, way before UNESCO biomedical workshops came. I think we did these workshops, and we developed all this teaching on medical ethics. There were some positives, there were some responses. And the first question which was asked, should we teach ethics to medical students? And one of the Thane IMA developed a big debate in their own conference, and there were stalwarts against me and Dr. Bapat, and we defended. And we said, yes, we need to teach some part of the ethics to our medical students. And in 2015, MUHS and NMC have accepted the bioethics curriculum. In fact, if you look at the DNJ in February 26 this year, they wrote a very nice article, when is the best time to teach medical ethics? And what we did in 2003, now they fully agree, saying that, yes, we need to teach them in the beginning of their first year medical students. And when I responded to them, all of them, it was a very positive response. Yes, we should start teaching people ethics in much earlier stage. Now, if you see, FAMER regional institutes was an attitude-changing experience. I thought whether we can try all this in India and all these other FAMER institutes which are there across the world. Everywhere people tried these techniques and attitude changing was possible. And this was very encouraging that when we work with people for a long period of time, I'm sure there is some degree of a change will occur in most of them. I'm not saying one or two we may not really find, but most of them will change their attitudes. So then I went to MHP, UIC, and I thought, when I went through that, rather than learning and getting the degree, what I realized was changing attitudes and behavior is the most important thing. And it is realized in everyday practice. And there was Ara and Eileen and everybody really started working on that. So when I got an opportunity and we got opportunity to really develop Vision 2015 in 2010 when the committee was formed. The first thing what we said that we have to introduce attitudes and in this particular kind of a curriculum. So before that, most of our curriculum was cognitive. There was some degree of skills, but attitude was very small amount. So the whole vision was that to try to change the curricular elements, that I'm sure the cognitive will still remain the strong because the knowledge is a very strong part of our curriculum. But we will add a good amount of skills and attitudes. Though not equally shared, cognitive will be always high, but we have to really make the presence of skills and attitude feel there. So we tried to bring a lot of newer elements. I will not talk about this because all of you really know what are these elements, and I will just talk about something which is not really there into this particular curriculum. And at the same time, Dr. Krishna, who is our colleague and he was an expert group member, came out with this wonderful concept of knowledge, skills, attitudes, values, responsiveness, and communication. And this is where we started working on the hidden curriculum, how we can make it explicit. And at the same time, I remember there were a lot of talks about violence against doctors. You know, every day we hear the news that doctor is being beat. And the main cause of that is communication gap. So we need to work on communication. So we brought ATCOM module. And this ATCOM module consists of knowledge, skills, attitude, ethics, and communication. And we try to add values and responsiveness. Now, this is something which is intended and it has to be really thought about when somebody starts working on ATCOM. So ATCOM module in 2018 was brought, though the work started in 2015. Ultimately, it was published in 2018 and we started training people much earlier from 2016. It was the first time professionalism was introduced in our country and which is much wider. Though there were mentions before, this was done little more. Well-developed modules. You know, we tried to use the modular approach, structured in graduate medical regulation, and customized modules to our settings. And we left it open for final answers because we thought if people discuss it, they will make aware students at the same time, the attitudes will change and they will be made aware students will be made. And there's a vertical implementation across curriculum. So we tried to balance attitude, ethics, professionalism, and communication. And we made it first year, second year, third year, fourth year. And we also want to propose in internship. Later on we can do, and we try to use case-based approach, stepwise modules, interactive teaching, and competency-based. So I'm sure everybody knows examples. What does it mean to be a doctor? Realizing the responsibilities, whatever is of value in the first year, at least the motivation is there. Respecting and honoring a cadaver. Definitely this has become very well known and people have started looking at it, the human body with respect. Communication skills, you know, William Osler said very nicely, there are only two sorts of doctors. Those who practice with their brains and those who practice with their tongues. Tongue is so important for a doctor and we should try to develop it in addition to the brain. So there are a lot of doctor-patient communication issues which we started working on them, and there are so many modules on communication. Breaking bad news, this was a neglected area, so I think people need a special training on this. So we try to structure it and try to tell people how to do it with workshops. Dealing with death, again, this is an extremely important aspect about the medical practice, and we need to really work on this in the last year. And I'm sure there are a lot of other things we can work in a postgraduate level on these topics. So we try to really tell people that use different kind of models, you know, seminars, guest lectures, movies, reflections, and the whole expert group, which included Krishna, Tejinder, and Praveen, Sajid, and so many, so many people really worked on these topics And we also use theatre of oppressed, I'm sure with Satendra and his team, and many other small methods we try to give people a showcase. So you pick up whatever you want to really use. So ADCOM was implemented through an MCA network of 22 centers, and it started in June 2015. More than 20,000 faculty trained in last 7 years in NCRC. Now ADCOM there are about more than 20 publications on ADCOM and its evaluation. And if you really see so many books now, there may be some commercial aspect, but what is good thing about it, people have tried to deliberate much more in detail about the whole ADCOM. There are so many publications and effectivity of ADCOM, responses, most of them are reactions. But I like the way country has taken this, not only in India, but all the surrounding countries, that people have tried to use ADCOM as one of the bases for introducing attitudes, ethics, and communication. In fact, this year, the students of second BBS have prepared this non-commercial booklet, and this is a students' initiative for ADCOM. So the students have now started accepting and preparing manuals, and this is a very positive step. Faculty doing it for commercial purposes is a different thing, but students doing it in non-commercial goals and accepting it is something which I feel very happy and proud that students themselves have realized the value of this, and they have started taking interest in this and start developing this. At the same time, we found that ACGME in 2012 started Milestone Project. And all of you know that knowledge, they had multiple milestones. Okay, thank you. If you really see the topics like facilitating patient and family involvement, then similarly, there are multiple levels, 1, 2, 3, 4. So now they have developed a framework on which we can look at the ascendancy of the attitudes and trustworthiness. Some of these topics which were never thought that we should really teach or we should assess, they have been now available there. We have a formula available there. We have a framework available. So this is very useful for us for assessment of these competencies of ADCOM. And then came EPA, which is a combination of multiple milestones in professionalism, patient care, and communication. So we started combining all these milestones to create an EPAs. So attitude training has now been taken up by different levels: NSS camps, medical camps, voluntary services, field trips. Sevagram takes students to the villages. CMC takes them to the secondary hospitals. There are many places you find there are different experiences people try. One of the things which we also tried was workshops on narrative medicines, which was very useful, I thought. There was a team from Philadelphia which taught us. And from 2016 till now, we have taken many workshops on narrative medicine. And there's an excellent feedback. I think people realize the value of narrative, and it really changes the approach with which the doctor listens to a patient. Listening is so important, and narratives probably help you to listen to a patient. Similarly, movies in medicine. Henry Colt, he was one Californian who wrote a wonderful book. So we have been trying to use these movies for people to make a point. So when GMR came in 2019, there was emphasis on attitude, ethics, communication, and skills along with knowledge. So I'm sure we are creating skill labs and competencies, but we also need to have effective domain faculty development. In fact, one or two institutions, I think Datta Meghe has started communication lab. There are many other places have started communication lab, which I personally feel is one more step into the whole thing. I would like to really tell you our experiences with these two: value-based education and humanities in medicine. Now, if you really see, value education is such an important aspect of the whole curriculum, which we normally do not really discuss. Now, I must tell you, one of my teachers who very nicely said, 40 years ago, when I entered this profession, doctors did not know much. There was no sonography, no CT, no MRI. When I was a student also, all these things were not there. In 74, I joined medicine. There was no sonography, no CT scan, no MRI. Diagnosis with uncertainty. We never knew what was in the abdomen. We used to do an operation called an exploratory laparotomy. And when you open, many times you used to find there's a metastasis, or what we thought something else comes. It was something like a diagnostic test every day. In spite of all that, patients still trusted our teachers as well as our colleagues that time. Today, doctors have much more information about patients and their diseases. Minute up to 2 millimeter, minute up to 2 millimeter, but still patients do not trust doctors. So probably the whole value system in society as well as the system is wrong. What is to happen, I'll tell you. About 70s, there used to be a patient who was little elderly, used to fall sick. People used to really try some medicines at home. After 2 days, they used to go to a doctor. Doctor used to give him the medicine and something, and the patient used to get well. And they used to thank the doctor, and they used to have a trust in the doctor. Today, whenever there is somebody sick, people start searching on Google. And they find out who is the best doctor who has a maximum Google review. And they start going to that doctor. When they go and talk to the doctor, they still don't have the trust in the doctor. They will check with the second opinion. They will go on Google and find out whether everything is right. If there's anything, they will say, the Google says this, why are you writing this? And anyway, patient will be all right after 2 days, and the doctor will get one more positive Google review. So the things have changed. The values have changed. In 1887, the classic picture of Sir Luke Fields, the doctor, is a doctor who is looking at this child. I'm sure all of you have seen this picture. And see the kind of relatives, his parents are standing, they know this is the early morning, you can see the sun rays, the child is almost on the deathbed, but the doctor is compassionate, he's looking at it, maybe he is telling the patient's relative that I am still with you, though I may not be able to do anything. And today, if you really see the Lancet 2019, look at a child drawing a picture of a doctor, when he says that the doctor is on a computer and he's not seeing the patient. Is this the image of a doctor we are going to carry forward into a profession? I think all of us need to really think about this, that what has happened to the empathy in the age of electronic medical record. Maybe this is all necessary. All of us practice it. All of us live on Google. But at the same time, we should also think about where are we going and where we should really go. So when we talk about values, goals, behavior, and self-value, values give direction and consistency to behavior. And that is very important. If you're honest, your whole behavior will be honest. If you're a thug, you know how you really behave in every aspect of it. Values help you know what to and not to make time for. And values establish relationship between you and the world. And that's what your image is. And all of us, probably at the end of the day, don't live. I'm sure people live for money for some time, but people live for values for forever. And that is what we should all matter. So values set the direction for one's life. So how does value develop? What is the role of education and sanskars enable transformation? Right understanding in the self. This is something which is very important. We should all understand what is in us and what do we really want to understand about us. Relationship with human beings and physical facilities with the rest of the nature. That will change understanding and transform from animal consciousness to human consciousness. And of course, it will have a mutual happiness and mutual prosperity. So if you really understand this whole concept of Sanskriti or values, it is very nicely said, if you have Prakruti, that is nature, if you look at it in a positive way, it becomes Sanskriti. And if you look at it in a negative way, it becomes Vikruti. So we have to really see how do we change this from animal consciousness to human consciousness. So your age will greatly influence your values. Different people and things influence you at different ages. Age 1 to 7, parents. 8 to 13, teachers and your heroes in sports, rock, or TV, wherever, or music. 14 to 20 is peers. Values because peers of peers because of their values. You have to really see how these are the areas when you're forming. And 20 when your values are already established. But you may test your values from time to time. Now, as a teacher, medical teacher, students come to you at the age of 17 and they are with you 22. So this is a time a good teacher can influence their value, the students' values. And we should contribute into this value education. And so values and behavior, happiness comes from letting values decide your behavior and goals. And values can change over a lifetime as your experiences change your view. I'm sure all of you know the story of Valya to Valmiki. It's a very interesting story in Ramayana. So there are different kinds of values: moral values, material values, aesthetic values, intrinsic and extrinsic values. And I'm sure there are different values. So if you look at the Fowler's theory, there were many values, religion and cult. And he had value of how the religious development really theories. We see all around that religious is used for so many things, including the politicians, for elections and everything. Every day we are surrounded by all this. But he had 6 stages of religious development. And it's wonderful to read this article of Erickson. And he really gave from intuitive to universalization of faith. And there's something called the world's value ranking. If you look at the world, they have different values which are pioneer. So like say India has, if you see family, then we look at work, then we start looking at the friends, then we start looking at the religion, leisure time, politics, something like that. A common Indian man would look at it. And this was a World Values Survey. And if you look at different countries, like say if you look at Middle East, religion is most important. Some people have work is more important. So I think everybody changes with where they are working. Now, if you look at our own mythology or our own history, if you look at Santa Gnaneshwar was a great saint in Maharashtra. And he really divided values into 3 areas: eternal, social, and personal. Very interesting. At the same time, Santa Tukaram was another saint who really talked about role modeling. And if you really look at all this, they talk about role modeling. And if you really go through them, you realize they had thought about all this much earlier and they made a change into the society. So when we talk about values and role models, values are imbibed by the imitating teachers, parents and role models. Values are imbibed by watching teachers in action. I think this is very important. It's not only what we do, because teachers are looking at you from all sides. Our students are looking at teachers from all sides and they follow them blindly. So students follow not only what teacher talks, but how he behaves. And I'm sure there is a lot of theory about mirror neurons, and there's a link between science, religion, and culture philosophy. So what needs to be done? We need role models. I'm sure there is no doubt about it. Everybody will talk about need for role models. Develop teachers with values. And we also need to talk about hidden curriculum and value-based education. And this is what we can really do. So when we talk about hidden curriculums, the hidden curriculum consists of those things the students learn through the experience of attending the college rather than stated educational objectives of such institution. So every institution, as a teacher or as a faculty member, you need to create some kind of a niche where we start building various values. Maybe it's honesty, maybe it's a transparency, maybe it's a trustworthiness, maybe it's a coming on time. These are simple things a teacher can really put onto the students where the values will be created. So we need to formalize informal. Now the question which remains is, will it work? Will students absorb and use experiential learning? I think over the last 40 years, I have tried all these techniques in very subtle way to see that my students absorb and develop many of these values. And now when I talk back to them, they remember how I behaved with them rather than what I talked with them. So it's very important that what you teach, more important is how do you behave. I think this is one lesson all of us should take with value education. So there are ways to incorporate values in curriculum. through role plays, morning presentations, reflections, the way you react to a simple issue, many gymkhana activities, co-curricular activities, group activities, taking students for hike, trek was our always thing. And I thought we could really make many of our students value differently the nature, work-life balance, reading and research, projects, debates on value-based topics, and offering social services on voluntary basis. Now, this is something which, if you do yourself, your students will start doing it. The second, what I want to talk to you is about humanities. Now, humanities is, I'm sure, wherever is the heart of medicine is love, there's also a love for humanity. I'm sure Dr. Tejinder came out with a wonderful book on humanities in medicine, and I really loved that book. But it really talks about humanity and humility. See, these words are so close, and they have a lot of closeness in themselves. So I was introduced to humanities in 2002 when I read this article. Medical humanities has been defined as integrated interdisciplinary philosophical approach to record and interpret human experiences of illness, disability, and medical experience. At that time, I just read it. I never realized that this is so important till the time. I think it has become now part of mainstream of education. However, I was invited by this journal, Indian Journal of Medical Ethics, in 2012 to write about medical humanities. And this was an eye-opener. I think I read about medical humanities, the literature, how the world has responded. And I thought this is something which our colleges need to have. But of course, this has to be voluntary. This can't be done. And if you really see, I also came across that time the Satyendra and his whole team, Navjivan, and I think they do wonderfully this theatre of oppressed. But that is only one aspect of humanities. Humanities is much bigger than this. And you see the MCI hall, which is such a powerful tool. So that, I thought, made me trigger that we should have Department of Humanities in our college. So when this idea came of Dr. Kothari, who was one of my teachers, he was professor of anatomy and a great philosopher and thinker. So when he died in 2014, we started this department in his name, Dr. M.V. Kothari, Chair of Medical Humanities and Department of Humanities. And it is from 2016 till today. It is running very well in KM, and we have an yearly conference by students, Ascension. Now, the philosophy is that the arts, humanities, and social sciences act as a counterbalance to the relentless reductionism of the biomedical sciences, which rely on knowledge that enhances the order and predictability of diagnosis, investigation, and treatment. So, humanities help you to treat your patients better. MCI and NMC now has formally introduced humanities in medicine as part of curriculum in early clinical exposure. So what did we really do? We have a every monthly there's an activity. And I'm just going to show you a few of the activities, but there are a galore of activities which have gone across last 5 years. Workshop on resilience. Now, this is not considered in undergraduate students. This is never taught. But this is something which should be taught to students about resilience that helps students to cope up better, not only through exams, but also in life. Panel on corruption in healthcare. This is something which and students contributed so much, and they came out with all this. Film shows and discussions. We had a lot of films like Gifted Hands, Patch Adams, Anandi Joshi, My Sister's Keeper. What is more important, you show a film into seminar hall, and then there's an active discussion by students and teachers along with the author if he's there or director who is there. What it means to be a patient, a disease experience. I think we had great partners. I mean, Nandini was one, Dr. Farooq Udwadia came, and so many experts who came. Dr. Pandya is our chair for this humanities department. We did also experiments like human library, narrative experience to one. In the evening, everybody sits on the ground and people share their personal dialogues like a book. In fact, I was very happy when Tejinder and his team, especially Anuradha and Tejinder, published this article in Journal of Poetry Therapy. I think to think like this, poetry in medicine, and write an article, I was so amazed that yes, people have started breaking the walls and thinking beyond the regular kind of books. So what are the challenges? This was an additional curriculum in a NEET era. What we find our students are totally engrossed with NEET. But this is an additional curriculum. Working after regular classes, you need to have an extra effort by teachers and students and funding. So fortunately, we had good donors, and so that was not a problem. So what we could achieve with this? Sustained Department of Humanities for 6 years. Active student participation. There's a monthly program which is attended by many people on various topics, from photography to poetry, and from, as I said, resilience to human library. There's an annual booklet on humanities, and in-house support and donations, something like that. And if you really see, for the things we have to learn before we can do them, we learn by doing them. So all of us probably learned, became teacher, but we learned humanities, probably all this on the job. So challenges of assessing affective today. Now let's come to, does this all work? That's the question everybody has. We are all doing. Does this all work? So if you really go through the David Stern's book on measuring medical professionalism, there are various ways you can do. I'm sure if you see so many articles are there, books are there, people have been using the workplace-based assessment, surveys, 360 degrees. Now our country is slowly adapting to this, but the kind of journey is going to be slow because these kind of changes happen very slowly. But we have started looking at it. We are aware of this. Awareness is the first step. Starting is the second step. And then people mastering it is going to be the third step. And I'm sure over a period of time, people use reflections, portfolios to learn all this. And it is going to be future in the next few years. So we also try to look at the program evaluation. So if you look at the evaluation of impact of interventions, especially humanities and value-based, there was a good reaction. People enjoyed the training. They had some transfer of their skills, which we could see their attitudes. We have to see whether they change behavior, because this is 6 years. When they go into the society, whether they will change. And when they perform, we'll have to really look and see what is the impact. So if you look at the articles, which are published, participants appreciated and highly valued steps taken by MCI to bring changes in existing curriculum. This is in Eric. And this is from Jipmer. And many agreed that MCI has stood up to meet the needs of the honor component of the education in India. And I think this was a very positive step. Look at Sirani Journal, 2021. Narratives and reflective writings are important tools for learning attitudinal and ethical issues. And I'm sure the outcome module helps students acquire necessary competence. Humanities promote competence. This was a very nice paper from UCMS, DMJ 2019, where they said some students may never witness such role modeling. Research suggests that creative instincts of medical students could be utilized through exposure to the humanities to explicitly develop these skills. I'm sure to collect evidence for such things is very difficult. But the kind of narratives impact experiences of students, and when you talk to them, it's extremely encouraging that these kind of changes, what you normally do, are definitely encouraging. Many PGA orientation programs have now communication skills as a very commonly taken topic. There are a lot of workshops done across the country. Even the ophthalmology, surgery, everywhere you find their publications also have come as a module for them. This is again 2019 in Indian Journal of Ophthalmology. The role of humanities in teaching medical students. This is one of the book which has come. And it really says we need to come forward to convince medical educators of how literature, visual arts, history or philosophy may help students to understand better of the patient's feelings on their own diseases. The poetry therapy, somebody may look very different, but it helps students to understand patients' feelings. Humanities are not a cultural curiosity in the field of medicine. They will help to train more empathetic physicians by showing the need for treating patients, not only diseases. And this is something which I thought is the thought process in including all these aspects. We should think widely. We should think patient as a human. We should think beyond the disease. And we should see that patient is treated as a whole rather than only painless kind of. Look at this conference, which is conducted by our students, for students, attended by more than 300 students across the state. And it has wonderful speakers, topics. I think the way I feel students have owned these kind of activities, I personally feel very happy that the students will learn on their own. And that's what matters to us. If you see, our medical students have taken a job of teaching slum children. And one day they have shared their experiences of medical undergraduates teaching slum children next to our in Vadala, that is about 2 kilometers from KM Hospital. And I thought it was an experience for me because my students, whom I have been trying to go, they are going on their own. They are working with an NGO, and these are all interns, or usually after doing their duty, they are doing all this. And they are trying to see slum children coming up. You know, I think this kind of a commitment, even if they do for 6 months or 1 year, and by rotation, the next batch does it, I still feel this is a great kind of an attitude changing behavior. There are commitment of interns and students to various programs, 1 week for the nation. So I feel some change starts coming where people start working for the patients. Now, today's student we find is engrossed with NEET. He has a dilemma of clinical training versus going to classes. There are some students who are aspiring for the research versus going to US. On the other hand, they want to try to make humanities. I'm sure one has to go beyond this dilemma. Maybe you can be a super achiever, but at least don't forget about the wider vision and humanities when you're training yourself into. Don't become a robo just to solve all neat MCQs. You have to think about making yourself a good doctor. And that is because a past was paternalistic kind of a patient. Patients used to trust you. Presently, it's all about diagnostic, data, stats, EMR and EDM, evidence-based medicine. But there's a lack of empathy and what is called as a cookie cutter approach. We are all about talking about standardized approach. But the future is going to be artificial intelligence. Future is going to be precision medicine. Future is going to be knowledge access become universal, and we are going to have personalized care. And this is where you will find patients will need much better kind of a personal thing. So in a professionalism and new era, I think if you read all of you, this is a wonderful article which came in winter of 2018, just 1 year before Corona. And it said that traditional model of professionalism is associated with virtues and ethics. And in 1992, 2 models of professionalism came: behavioral model and competencies model. Translating ethical instruction into ethical actions, that was behavioral model, and demonstrating professional competencies like ACGME and milestones was a competencies model. But he says there's a recent model of professionalism, and that is professional identity formation. Approach developed in reaction to concerns about the reductionist behavioral model and describe the progressive incorporation of the values and aspirations of the profession into identity of a person as a good physician. So we want to make or value the goodness in a physician. And if you want to really bring that, that is going to be the professionalism of new era. And this is all over, maybe east or west, everybody is talking about this. And we all have realized it when we are trying to treat patients. So to end, summarize what I would like to really say. New initiatives such as ATCOM module, foundation course, humanities are likely to bring paradigm shift in medical education. And that is what is necessary. How early it will bring, how much it will bring, we have to really see the time. But I personally feel making students aware and buying them at an early stage will probably have a long-term impact. And we will start seeing it after 2 years. ATCOM training and other activities like humanities will emphasize professionalism. Existing faculty development network, curricular governance, and educational monitoring will help in implementing these kind of curriculums. Values are important for medical professionals. Values are imbibed by students by observing parents, teachers, and role models. All of us see, if you look at your own child, how do you really bring him up? Values are so important, and all of us live on values. And we have to see how we impart those values to our students. And attitudes need to be imbibed through formal and informal training and hidden curriculums. As a teacher, we may have a prescribed curriculum, we may have a framework of hours and competencies and everything, but we still have the leeway of a hidden curriculum, various activities done in a school, a medical school, a teacher. I think there are so much a teacher can give to a student to change the attitude. And I think that is what we have to do, because that is a thing which will happen throughout the careers of us. And today, when I look back, after say 40 years of teaching and students, and when a student sees me after a few years, and he always says, "Hello sir, how are you?" He goes on telling you stories, what he liked and what he did not like. And that time he says, "Sir, we like the way you behave, the way you taught us. This is something which we liked of you." Then you realize, yes, values are more important. Honesty is more important. Transparency is more important. Trustworthiness is important. Students should have faith in you. Students should believe, they should try to follow you. I think this is something which we all live for. And therefore, I think we need to strengthen this medical professionalism, because that is what will remain in this world of artificial intelligence and data science for a doctor to really strike out. Thank you so much. And I would like to end by showing my gratitude to many. I think I would like to first say that I was blessed with role models. Lucky to have my teachers. And I would like to give gratitude to all my teachers. I would like to show and talk, few of my teachers where I put my pictures, like Dr. Kothari, Dr. Balerao, Dr. Samsi, Dr. Bapat, Dr. Mathu, and Dr. Lopameta. These were my teachers. But I had many teachers beyond KM. Dr. D.K. Srinivasan, I already told. Dr. Professor Blumgard, who was my teacher at Sloan Kettering, a world-known hepatobiliary surgeon. Professor Sohendra was a world-known endoscopy surgeon. Then Eileen, then Tej and Ara and D.K. Paul sir, Prakash Mishra sir, all of them probably helped me to shape up and understand beyond KM. My expert group members from 2010 to 2022. Dr. Rajlakshmi, who is the backbone of the expert group, and all the stalwarts you're seeing, Krishna, Tejinder, Sajid, Vijay, Praveen, Sajid, Chalam, and Saubir, and of course many who came with us, Alka, Sunita, and I think they all helped us to really do all this. And not to forget, and now is my whole GSMC KM team. Our KM unit was so strong in medical education, and we really developed 2 or 3 layers. So in spite of all of us have retired, I think the KM medical education unit and department is so strong with Henal, Praveen, Munira, and so many others which I can take their names. So all of them have contributed immensely, and I would really feel happy that we could do this. So let's do this together. Strengthen the medical professionalism, because after a few years when we go back, the new generation should not ask us whether we did not make an effort into this. So thank you so much, and I would like to give my thing back to Purnima. Thank you so much.
Thank you so much, sir, for this very informative, very illuminating, and this awe-inspiring oration. We all are, in fact, spellbound. Thank you for sharing your journey with us, sir, and to tell us threadbare of what all went into developing professionalism in our context, Indian context. And of course, the way forward. I'm sure all of us have benefited immensely from this talk of yours, sir. And this is today's mantra about developing values and ethics and professionalism among the students and all of us, in fact. With this, I hand over to Sanjay Bedi, sir, to hand over the honor, to do the honors to Avinash Supe, sir. Sanjay Bedi, sir, please.
Thank you, Purnima. I mean, indeed, we are all spellbound, and the way the journey has proceeded, it's something like a divine track. He has acknowledged all his teachers, and they have all come to as if the big energy has come together in the form of Dr. Avinash Supe. I mean, drawing from all the resources, and I have known him since 2007 when we did CMCL Famer, and since then he has been directly and indirectly promoting MEU India, encouraging us, and gradually we are. He is also one of our mentors, and we are very grateful to you, sir. And we, on behalf of MEU India and all the participants, we confer upon you the Lifetime Achievement Award. But although we are very sure that many such achievements will be coming in the coming times, and also we can we thank you for taking up this Rita Sood Memorial Oration on strengthening medical professionalism. Thank you, sir.
Thank you so much. Thank you so much. It's a really, I gracefully accept it, and it will be an honor for me to accept this. Thank you so much.
We have a lot of gratitudes are coming in the chat box also, and with this we end this session.
Right, sir.
Thank you, Purnima. Thank you so much.
Thank you and good night.
Ministry of Health of India and to the Drugs Control Department.